further ado, Vincent, I'd like to hand over to you. If you'd like to take over.
Thanks, Matthew. Let me just get set up. Can you see my presentation? Matthew?
Yes, Dr. Pretorius, we can see it clearly.
Okay, great. Okay, awesome. Thanks. Good morning, everybody. As presented, my name is Vincent Pretorius. This is my first time on the platform, so thank you for the opportunity to present on the topic of sialendoscopy. As you can see in the picture, I'm a consultant at New Somerset Hospital, which is where I was introduced to sialendoscopy by my predecessor, Dr. Oscar Atkins. So I started doing them after he left about a year ago. So I will be talking about sialendoscopy. Let's see. There we go. I don't have any disclaimers. These are the things I'll be covering. So sialendoscopy from an endoscopic point of view is fairly new compared to other endoscopic procedures. And it was first sort of tested out by Dr. Philip Katz in 1990. And this, in this situation, used a flexible mini endoscope and introduced it into the salivary gland and was actually able to visualize a stone in the duct. But obviously at this point, he was unable to do any intervention, but this piqued his interest. So I think even in the beginning, they already saw the potential of what could be done with sialendoscopy. A few years later, Nagliele et al. Used an arthroscope. It's a scope that's used quite frequently by the maxillofacial surgeons. And they use that in conjunction with a suction into the salivary duct, visualized the stone and was able to bring the stone into a more proximal position, but again, without any further intervention. In 1997, Nagliele et al. Then first published his first case series where he used 3 different types of scopes, 2 different cannulas with a 0 degrees camera and then a 30-degree camera. And then he also used a 2.5 millimeter pediatric urethroscope with a working channel and started sort of doing investigations and diagnostic scopes on different populations. Marshall, who's one of the pioneers in sialendoscopy in 1999, publishes his first experience with the 1.3 millimeter sialendoscope. So the pioneers of sialendoscopy, Drs. Katz, Nagliele, Marshall, Iro, and McKirk, found it very difficult to accept that with obstructive salivary gland disease that you have to excise a gland when you can just potentially just address the problem by extracting a stone. So why sialendoscopy? So sialendoscopy is, as the word says, is an endoscopy of the salivary glands. It's minimally invasive. It can be diagnostic and therapeutic at the same setting. And it addresses not only functional problems, but also structural anatomical problems. For example, it's quite effective in the management of stones, plugs, strictures, and debris. Once you become more proficient in the procedure, it can even be done as an outpatient procedure. So that negates sort of the waiting time that you have to wait with available theater time and a general anesthetic and so forth. It also avoids the complications from open surgery. It is obviously cosmetically more acceptable. And one of the major benefits is that it's a gland sparing procedure. Many glands removed from obstructive symptoms has been shown to have normal histopathology. Marshall et al. Also showed in one of his series that on histopathology that the anatomy of the gland does not correlate with the clinical history. So some glands would have, single episode of sialidinitis and they would remove the gland, find the stone, and the gland would be completely obliterated. While other glands would have a multiple or prolonged history of recurrent sialidinitis, and then they would remove the gland and find a fairly normal functional gland. And then it was Turner and his team that saw that by removal of just one submandibular gland, it actually can cause a decrease of salivary function of up to 15 to 35%. So I'm going to very briefly just go through past some of the anatomy. We're all fairly familiar with the anatomy of the major salivary gland. So the sialendoscope is mainly used for the major salivary glands, and the parotid gland is the largest of the lot. It weighs about 15 grams. It's within the investing layer of the deep cervical fascia. And the duct is the Stenson's duct, and it comes from the anterior border, and it runs about a finger breadths width just below the arch of the zygoma, so 1.5 centimeters. And it runs forwards and slightly downwards, and then hooks around the masseter muscle, pierces the buccal fat pad, the buccinator muscle, and then the buccal mucosa opposite the second upper molar. It's lined by cuboidal epithelium, and it's about 5 centimeter in length. And you can see the internal calibers on average about 0.6 millimeters, which is quite small. From an external point of view, the buccal branches of the facial nerve, you will always find lateral to the duct if you explore it from externally. If you want to use surface markings to identify your duct, you can often just palpate it by rubbing your fingers. If you clench your jaw, you can rub your fingers over your masseter, and you can often feel your own Stenson's duct. But the surface markings, you can find it by using the intertragal notch and drawing a line to the midpoint of your fulcrum. The other major salivary gland, which is often affected by obstructive disease, is the submandibular gland. Is the second largest. It's J-shaped. It's at level 1B of the neck, and it wraps around the malar hyoid. The duct length is the same of that of the parotid gland, 5 centimeters, but its lumen is larger. On average, is about 1.5 millimeters. Both of these glands, the duct is narrowest at its punctum or the ostium. The duct emerges from the medial portion of the gland and runs on the floor of the mouth between the malar hyoid and the hyoglossus, and it exits by the papilla adjacent to the lingual frenulum. Anterior to the distal end, you will find the sublingual glands, and posterior to the distal end, you can find the lingual nerve. If you look at this little diagram on the left, you see in the posterior part of the mandible, it starts in the lateral part of the floor of the mouth, crosses the nerve, goes underneath and wraps around, and then comes up medial to the nerve in the distal end. And you sort of need to be aware of the anatomy of the nerve, especially if you do combined or open procedures. The sublingual gland has got multiple excretory ducts that also drain into the main Wharton's duct. So the most common indications for using a sialendoscope would be for obstructive causes, and most of the times you will find that in obstructive causes it affects glands unilaterally, but it can be bilaterally. The most commonly we can find stones, strictures, mucus polyps, and even foreign bodies have been described to be found within the duct. Then salivary gland stasis. So these are the functional issues that you can find with the salivary gland, where the sialendoscope is also quite useful, is in autoimmune disorders, most commonly Sjogren's disease and IgG4 disease. And then a special mention about radioiodine sialadenitis. So it's also been found that about 24 to 25% of the radioactive iodine that is given to patients for thyroid carcinoma gets excreted in the saliva. And the accumulation, the concentration of the radioactive iodine in the glands is up to 20 to 100 times of the concentration that you can find in the plasma. So it's easy to understand why you would have a sort of inflammatory response taking place in the gland. And then very rarely you can also find it where you have masseter hypertrophy and you get a kink in the glands that can lead to stasis of saliva and secondary infection. So if we look at sialolithiasis, it's 50% of major salivary gland disease is made up of sialolithiasis, obstructive gland disease. It has a prevalence of about 1.2% on post-mortem studies, but less than 1% of the population will be symptomatic. So it's fairly rare. And I must say from personal experience, we see about, we normally group them at our institution, and we would see about 2 to 3 every 2 to 3 months. So we're not a high volume center. And if we look at the involvement of the glands, the submandibular gland will be involved about 80% of the time compared to the 20% time of the parotid gland. The stone is normally made up of a organic center, which can either be cellular debris or bacterial debris or any sort of stagnant part of the saliva. And then that forms as a nidus for the anorganic calcium phosphate and calcium carbonate that starts forming sort of layers around the stone. And the diagnosis is normally based on your clinical history, your physical examination, and imaging studies. If we look at the study from Koch and Zenk, they found in their sort of case series that you normally find the stones in the majority of time at the hilum of the gland. But this varies across different sort of literatures and articles that I've read. Some articles find it most commonly in the distal part of the Wharton's duct, and very rarely people can find it in the parenchyma itself, specifically in the submandibular gland. So the classic history is where you get periprandial swelling associated with discomfort and pain. Now this can also be quite variable depending on the morphology and the characteristics of the stone. You can imagine if it's a small sort of floating stone that moves up and down the duct, the swelling can sort of come and subside, and there's not this consistent or history with periprandial sort of swelling of the gland. Well, if you have a stone that's impacted in one of the major ducts, you will have this periprandial swelling, and that swelling can persist for quite a long time. Sometimes when the stone dislodges, you can get this cloudy, thick saliva draining from the punctum with this offensive taste. And occasionally, especially in younger people, they will give you a history of being symptomatic, and then there's an expulsion of a small stone, and then the symptoms resolve. If this does happen, I would definitely not immediately take these cases for sialendoscopy. There's definitely a room for conservative management and wait to see if the symptoms do reoccur or not. And then it's important, as I mentioned before, to get a history of radioactive iodine therapy or previous surgery, dental surgery procedures, or trauma. The physical examination, we would start off with inspection. So external inspection of the face. Is there any facial asymmetry, swelling of the preauricular area, swelling of level 1 in the neck, any glands, is there any weight loss? And then if you open up the mouth, you start inspecting the oral cavity, look at the mucosa, inspect the papillae. Also to prepare yourself for before you go into theater. Is it present? Because it can be absent. What is the position of the papilla? Is there any salivary flow coming from the papilla? So you would then proceed to massage the gland and see what kind of saliva comes out, and if any saliva comes out of the gland. Now, of course, it's important not to do this in the acute setting if there's acute sialodenitis, because that would be extremely painful for the patient. So in the acute setting, you would normally treat them with antibiotics, wait for it to settle, and then bring them back and then do this physical examination. Especially regarding the submandibular gland, bimanual palpation is extremely important. We're talking about sialolithiasis mainly, but you should also exclude other sort of intraglandular pathology, be it benign or malignant pathology. So that's why it's also important to proceed with your head and neck exam. Look for your cranial nerves, your facial nerve, your lingual nerve functions, and then also remember to examine the neck for any adenopathy. So in the beginning, when we started out, the initial sort of investigation of preference was X-rays, where you would use occlusal views. But we know from experience now that 20% of submandibular stones are radiolucent, and in the parotid gland, up to 70 to even 80% in certain series of stones are radiolucent. So it's not a very sort of effective investigatory tool. If you look at the picture here on the bottom left, they describe the halo sign. So this is a massive calculus in the anterior floor of mouth, and even there it's not very clearly visible. Then the second investigation, which was used more traditionally, but is still being used in certain institutions today, is sialography. This is done by interventional radiologists. This is where they cannulate the duct, inject a contrast, and this gives you a very good sort of visualization of the ductal structure. Are there any strictures, any dilatations or filling defects? But it is quite invasive, and depending on the institution and the experience of the people doing it, has quite a high failure rate. This can also impact your ability to proceed with sialendoscopy if there's any trauma caused to the punctum or to the duct itself, and might make a sialendoscopy actually impossible. Further on, the contrast that was used can also induce a sialodenitis, which is not, ideal. MR sialography is a much, much better option. It's non-invasive. There's no contrast used. And the image type that they use is heavy T2 weighted images. And that's sort of with digital subtraction, and that sort of emphasizes the fluid in the obstructed duct. So it makes it clearly visible. It's quite a good investigation. Its sensitivity ranges from 70 to 90%. It has a positive predictive value above 90%, as well as a negative predictive value above 90%. But obviously it is quite expensive. So this is just a diagram that is in Scott Brown, looking at some of the pros and cons of the different investigations. And the main deterrent for MR sialography is the high cost. So I think I would recommend using it as a second line investigation where there's recurrent cases, or you fail to complete your sialendoscopy and the patient comes back with symptoms, or if you're unsuccessful with your other investigations. In American, the Western countries, their first line or their gold standard for their first line investigation is CT scan. But I think in the African countries and also in European countries, ultrasound is our gold standard. It gives you info of the duct as well as the morphology of the gland, and you can evaluate the neck if indicated. It's non-invasive, it's cheap. You can do it very quickly in your outpatient during your consultation if it's available. It has a Doppler function to evaluate the vascularity of the gland itself. And it's also very helpful in making a diagnosis of recurrent juvenile parotitis. And if you incidentally might find a mass within the gland, you can also do an ultrasound guided FNA at the same setting. But as an investigation, obviously, like anything, it has its limitations. There's especially difficulty in the anterior floor of mouth, where you can get a shadow effect from the mandible. You cannot, if there is a stenosis or a ductal scar, it's very difficult to determine the length of the stenosis. As we all know, it is quite operator dependent. And studies have also shown that smaller studies, some studies say stones less than 2 millimeters and others say stones less than 3 millimeters, do not have an acoustic shadow. So it's very difficult to pick up on ultrasound. And those smaller stones are actually the ideal stones for sialendoscopy. So its sensitivity varies from 94 to 97%, depending on the center. Obviously, it'll be higher in higher volume centers. CT, as I mentioned, also has a very high sensitivity and specificity, and it's good, obviously, for picking up the calcified stones, but there's a cost associated. I would also sort of recommend that you do a pre and post contrast sort of study, because you don't want to do an uncontrasted study and then miss maybe intraglandular pathology. It is also particularly good at picking up intergranular calcification, like you would find in patients suffering from alcoholism, chronic kidney disease, HIV, and chronic autoimmune diseases. When looking at contraindications for sialendoscopy, the only real contraindication, or the most sort of major one, is if there's in the acute setting, acute inflammation or acute infection. The duct becomes very edematous and very friable, so it's very easy to cause trauma in the duct, or cause a laceration and have complications from your procedure. Very rarely you can have complete atresia of the duct, so that would negate sialendoscopy, so you'll have to go to an open procedure. And then abscess formation distorts the anatomy of the duct, which can also make it very difficult, but that's a relative contraindication. And then also you have to consider your access intraoperatively. So if you have a patient suffering from quite severe trismus, whatever the reason may be, it might impair your access and your angle of accessing the more proximal parts of the submandibular and the parotid duct. So as I mentioned at the start of the talk, I only started doing sialendoscopies at the start of last year. So, but this is sort of the steps that I follow when we do sialendoscopy. Now, it can be done under general anesthetic or under local anesthetic in an outpatient setting, but I would highly, highly recommend when you start off with this procedures to start off under general anesthetic. It's got a steep learning curve. So you need sort of, patience, and you need time when you start off with these kinds of cases. Your patient, it will be in a supine position. We do a nasoendotracheal intubation, so you have good access to the mouth. And then your patient can also be in a semi-phallus position where their head turned towards the right, when the main surgeon would then stand on the right-hand side of the patient. To open the mouth, you can either use a mouth gag or a bite block. And then what I like to use is a swab holder with some swabs to push the tongue sort of cranially and more posteriorly. That does two things. It's non-traumatic, and it also absorbs some of the saliva that you find intraoperatively. Then the next step would be to identify the punctum. It's more readily found with Stenson's duct, but it can be extremely difficult finding it in the submandibular gland. A colleague of mine, Dr. Mayer, uses a microscope, which works very well to find the punctum, and I prefer to use my loupes. I seem to have a bit more success with my loupes. Again, to emphasize, if you compare it to, for example, like septoplasties in rhinology, finding the right submucoperitoneal plane, that's almost the most important part of your procedure and can take up the most time of your procedure. And that's the same with sialendoscopy. Finding the duct and atraumatically dilating that punctum can take up most of your time. So take your time and be cautious and be gentle. So then so there's two ways of doing it. You can either start with your conical dilators to dilate your punctum, and then serially sort of use your lacrimal probes, your standard lacrimal probes, and gradually dilate your duct from a 0000 to, it can go up to 8, but I wouldn't recommend going above a size 6, because otherwise you'll start causing micro tears in your duct. The other way of doing it is starting with a 0000 just to get the course of the angle of your duct and finding is it patent or not, and then switching to your conical dilators and then going back to your lacrimal probes once you've dilated your punctum. Very important, remember to white balance your endoscope, and once you introduce your endoscope, you have to confirm that you're in the intraluminal space before you start your saline or your Ringer's irrigation. Because if you are in a false track and you start irrigating, the floor of mouth will swell up, or the buccal space will swell up, and then you have to abort the procedure. Then depending on your institution and the equipment that you have, you can use a guide wire. Now we have tried with using guide wires from urology, but we find them to be a little bit too big for sialendoscopy. But if you can find your track with a guide wire here, you can sort of railroad your scope over the guide wire to find your way into the lumen. So these are pictures from an outpatient procedure, and you can see the position of the tongue, and that's sort of the position you want to obtain when you do it intraoperatively as well. We have these atraumatic forceps that we use, and you can sort of clench the area to try and straighten out the duct. You use your conical dilators on the right, and you can see that's the lacrimal probes that we use at Somerset as well. So looking at our equipment and looking at our scopes, the scopes that they started out with in the beginning were very rigid scopes. So the newer ones, especially the Erlangen one from Storz, it's a semi-rigid scope. So these are quite flexible, and that's important because you don't want your scope to break with these procedures. They come in a variety of sizes, and the two main sort of types that you get are the modular sheaths ones and then the all-in-one units. And we at Somerset, we use the all-in-one unit. These scopes have two different types of tips, which can either be the straight versus the off-angle tip. And I'll show you an example of those. So this is the modular scope. The modular scope has these three different sheaths that you put into your duct, and then through one of these ports, you would then introduce your camera, and the other port that you can see next to it then can be used as a working port or an irrigation port. These tend to be longer in length and a lot more fragile. They break a lot more easily. The integrated scope, of the all-in-one scope, is composed of both the imaging systems and then the working channels. And you can see with a cross-section of the silent scope, you can see the output illumination is intertwined with the input imaging sort of fibers in the silica glass there. So the other thing that's very important to note is don't expect to get an image the quality that you get with sinus surgery. Because of the size of the scope, the images are very speculated and quite small. And depending on the system that you use, it's very important to get an enhanced system that's able to enhance your image. As you can see in the slide on number 1 there, it's not very clear, but once you start enhancing your image, you can clearly make out the one on the right hand side. But again, it's not a very clear picture. Another tip, and which is extremely important, before introducing your scope, it is extremely important to check your orientation of your scope before introduction, because once you intraluminally, it's very difficult, especially when you go around bends, to know what is up, what is left, what is right, and what is down. So do that before entering your duct. So this is the integrated system with the straight tip and the sort of the working channel and the irrigation channel all in one. And this is the scope that we use at New Somerset. Here on the right, you can see this is the angle tip. And this is very helpful when you sort of have to, with the parotid gland, for example, where you have to go around the masseter muscle. So they would recommend obviously having a different array of different sizes of scopes, but the ones that we normally commonly use is the 1.3, that is your workhorse. It's suitable for most patients and it has a working port. For pediatric patients, if we just want to do irrigations, we use the 0.8, but the 0.8 scope does not have a working channel, but it's good for diagnostic purposes. So the rest of the armamentarium, your camera set can either be digital or HD. As I mentioned before, HD, it's preferable because you can enhance your image and make it more clearer. You get your probes and your dilators, as mentioned, from 0000 to 8, but I wouldn't go above 6, which is quite handy, but we don't have them. Our bougies, so they've got a hollow center and you can sort of thread it over a guide wire if you've got possible. And then also that's used quite commonly in the UK from Cook Medical is the disposable dilators, and I'll show you examples of that. They come in 2 sizes, a 4 French and a 7 French. The microforceps are also shown examples, 2 different sizes. These are very handy if you have stones of 2 millimeter size or less, or maybe pushing 3 millimeters. You can also even use it to remove ductal scars and some debris in the duct. Microburrs is for your intermediate size stones. It's hand-driven burrs. You can fragment your stones to make the pieces smaller and then retrieve them using stone retrieval baskets. And then for stenoses or strictures, balloon dilators are very effective. Again, we don't have these. We just dilate with our camera set itself. Certain camera sets actually, or scopes, have a bevel tip to make dilating a little bit easier. But then again, it would be ideal if you have different sizes scopes where you can start with a smaller scope and gradually dilate your stenoses with larger endoscopes. But if you have it available, you can use a balloon dilator. Then different people have developed different stents. The one that you can see in the bottom is a more permanent stent, also developed by Nagliele. And you can see it's got these lot of hooks so that once it's placed, it can't be removed, but I wouldn't recommend that. These are the bougies that I spoke about with a hollow center tip that you can thread over your guide wire. And you can see from the one with the smallest diameter, you can gradually increase your size to especially for distal stenosis, these work very, very well. On your right is a picture of the grasping forceps, or even we can use it for biopsies. These are the lacrimal probes that we use at New Somerset. They work very effectively, and it has a nice blunt tip, so it doesn't easily cause a false tract. So the Cook Medical introducer, it's called a calendar introducer. You can see this blue sheath with a little introducer. This introducer has a sharp tip that protrudes at the end to make introduction into the duct nice and easy. Then you remove this inner cannula, and then you can see at the bottom, you can introduce your scope in and out. This is quite handy if you sort of have to go in and out with your scope, removing multiple stones and fragments without causing trauma to the duct. Again, this is also not available in South Africa. This little blue sheath is hydrophilic, and so when it gets wet, it becomes nice and slippery, so that's also sort of protective towards your endoscope itself. This is, I would also recommend highly, using in an outpatient setting where you introduce once, the trauma and stretching of the gland happens once, and then you can work through that port. So looking at our workhorse, the baskets for sialolithiasis is the baskets. You get 2 different designs, the lateral engaging and the front engaging. Type A here on the right, that's the lateral engaging. These are the ones that we use. And then on the right hand side, you get the front engaging. Now the front engaging is really useful for stones that you can actually bypass, you can come around the stone. But if you've done a few of these cases, you often find these stones that are impacted in the duct. So that makes using the front engaging stone quite difficult. So the idea is to push the basket past the stone, and then with a sort of twisting movement, wrap it around the stone and then remove it with your endoscope. So you get the more common ones when you look at the baskets, you get a 4-strand or a 6-strand, and you can see in the number A, there's also a 3-strand basket, but it's not so commonly available. Then you also get the tipped ones, as you can see with A and C, and the ones without a tip, as you can see with B. Now the tip is quite handy to get past or around the stone to sort of that you can use, because these wires are quite flimsy. So to try and force them past a large stone can be quite difficult. So the tip can help you sort of guide your wire past the scope. But even though they're blunt, they can cause sort of ductal laceration. So you really have to be careful with those. So like I said, you can either use an introducer or direct access. Another important thing is it's important to keep your lumen centered on the screen. And another very important thing is as you go around corners, don't just keep your eyes fixated on the screen. You sometimes have to look at the position of your hand and your scope to make sure that your scope is not bent at too obtuse angles. Then stone identification, it's very important to look at a few things. The site of the stone, so the proximity to the papilla or to the gland, the shape of the stone, because that will sort of predetermine your success or your success of being able to remove the stone. Because the stone can either be oval shaped or round, so that will make removal more easy, or it can be like a staghorn shape, with obtuse angles, and that can make it a lot more difficult to remove. It can either be impacted or it can be a floating stone. And you can imagine a floating stone would be much more easy to remove. So here are a few images. You can see this is the main bifurcation with the first generation of ducts. You can see the impacted stone on the left-hand side. So what you would do here is you would actually put your endoscope in the normal duct and try milking out that stone into the main duct. Once you have the main duct, you will push your basket past the stone, and then with a clockwise or counterclockwise rotation, you would sort of envelop the stone. You don't just pull out the stone, you always keep it in direct vision and remove the basket along with your camera in one pull. And just be careful around the punctum because it can get stuck at that area. In the middle image, you can see this is the 3-strand basket. I think 3 or 4 strand is ideal. The 6-strand one, it becomes a little bit difficult to wrap around the stone if there's too many wires there. So I would prefer using a sort of a 4-strand or a 3-strand basket if you have the opportunity to choose. So apart from stones, the other thing that we also look at is the quality of the duct. So you can see here in the first image, you can see a nice, so the epithelium of the duct is actually quite translucent. So underneath you should be able to see this red hue of the blood supply to the duct. And in situations like recurrent juvenile parotitis, you would classically see this white sclerotic duct with some debris in the middle. And once you start your irrigation, you would also notice with a little bit more experience, you can start noticing when there's a sort of, when the duct is stiff and doesn't sort of expand with the irrigation. Not only do you get that with inflammatory disorders, but on the right-hand side, you can see examples of where stone was removed with a normal, healthy pink duct. And at the bottom, this sclerosed white duct from chronic inflammation. And you can see there's some web formation or diaphragmatic stenosis distal to the stone at the bottom images. So stenosis versus strictures. A stricture, they defined in the textbook that I use as the reference as a focal circumferential narrowing that is more luminal. So this is classically where you see an impacted stone, you remove the stone and you see the soft stenotic segment with a little bit of debris floating around from the stasis caused by the stone. These tend to respond very well to just simple dilation with an endoscope or even with normal steroid irrigation. So these respond very well. Then you get stenosis. These are more So they're a bit longer and they're more transmural. They contain a lot more scar tissue and they're a lot more resistant to just regular dilatation. So these are the types that would be more amenable to prolonged stenting. Stenoses or strictures are the second most common cause of ductal obstruction, with 75% of them occurring in the parotid gland, and most commonly in the middle part of the duct. There's a predilection in females in certain studies, and the assumption is that because autoimmune diseases occur more commonly in females, that is the reason why you would have strictures and stenosis more commonly in female patients. The success, as I mentioned before, is predetermined by the site of the stricture, the length of the stricture, and if it's a stricture or a stenosis. Endoscopy, like I mentioned, is particularly successful for the short strictures in the focal areas. And you would, when you address these strictures, you would start with the least to the most invasive techniques. Regarding strictures and stenosis from inflammatory gland disease, they have a higher complication rate, be it from endoscopy with sort of ductal trauma, or even with open procedures. If you do a parotidectomy for obstructive gland disease and there's been autoimmune diseases, your chances of getting a facial nerve paresis is a lot higher. Your dissection is a lot more difficult. So these strictures and stenosis are caused by autoimmune diseases, like I mentioned, like Sjogren's disease, radioactive iodine-induced adenitis, even sialolithiasis, external beam radiation. And sometimes we even see it with ductal reflux, where you marsupialize a gland, you scope it, it's normal, and then the patient can come back with strictures and stenosis from reflux into the duct. It can be iatrogenic from your intervention. It can be from trauma, and then you can also congenitally get these ductal folds. Now, Gillespie and his team, along with Volvacar, suggested this gland sort of problem-based approach to gland-preserving salivary surgery. And this is I find this is quite a nice breakdown or a tick sheet of things that you have to evaluate with every sialendoscopic procedure. And as I mentioned, what's the color of the duct? Is it pink and sort of salmon-y color as a nice pink hue? Or is it avascular? Is it erythematous? Is there dilated? Are there dilated vessels? Is there a lot of edema? Is the duct pliable or is it stiff? And then the location of your scar in relation to your ostium or the middle duct or the hilum. Is it in the primary branches or the secondary or the tertiary branches? Is there stricture or stenosis? And then also they recommend this grading system, almost like the Cotton-Meyer system that you get with subglottic stenosis. But here you can see you have to have sort of different size scopes to be able to grade the narrowing of the duct. So we don't really make use of this because we don't have all the scopes available. And then they go into sort of description of the different types of stenosis where you, like I mentioned, have either inflammatory scars or very fibrotic long stenotic scars. As I mentioned before, so they describe having sort of high pressure and low pressure balloons. This is the example of one of the sialendoscopy balloons. So these can dilate up to 3 millimeters in diameter, and you would normally inflate them up to 8 atmospheric pressures, and you would normally leave them inflated for about 30 seconds. So that's what they describe in the textbook. This is a stent from Schiatkin. So this is very nice. You can use the guide wire and introduce your stent over the guide wire, and it has these little sort of ports at the exit part, and then you can suture it to the mucosa. So what do you do if the papilla is not visible? I think if you're starting off with sialendoscopy and you are not very experienced with open procedures or familiar with the anatomy, I think it would be advisable to discontinue. If you do continue with a combined or an open procedure, you have to remember that you've had to consent the patient pre-operatively. Second thing is you have to assess your access into the intraoral cavity. Do you have enough access? Do you have an assistant to retract for you? What's your visualization like? Can you get good lighting down there? Because it can be quite difficult in the back of the mouth, especially in the posterior part of the submandibular duct, close to the hypoglossal and the lingual nerve. Open procedures have a higher complication rate. And if you do convert, have you set up your facial nerve monitoring system if you're addressing an issue in the parotid gland duct, for example? So you have to be confident to abort procedure if you're not comfortable with this. And I think I would also recommend, before proceeding with an open procedure, you have to be sure of your preoperative investigation of exactly what you expect to find, so that you don't unnecessarily do an open procedure and then you're still not able to address the pathology or reverse the obstruction, and then have to go back again to do a parotidectomy, for example. If you're struggling to find the papilla, a nice way to look at it in the floor of mouth, for example, it's often quite symmetrical. So you can look at the opposite normal side, find the punctum, and then in the same area, look at your pathological side. So if your papilla is not visible, or you're unable to dilate or enter or cannulize your papilla, they recommend doing a cut down procedure. You either make a circumferential cut around the papilla, say for example in the Stenson's duct, or you can make a U-shaped sort of cut into the mucosa anterior to the papilla. And then you sort of try and do a blunt dissection once you've gone into the buccal space and dissect out the duct. Then you can make a 1 millimeter cut in the duct just proximal to your stenosis and introduce your sialendoscope through there. What is quite important when you do a cut down is, and I've also learned the hard way, is if you make your cut too big, if you introduce your endoscope and you start your irrigation, most of the irrigation fluid runs out, and then you can't sort of stent open your duct, and then visualization becomes even more difficult. And even before you address your papilla, it's important to look at the rest of the ductal system. So you have to go all the way to the hilum, check your intraglandular ducts as well, to make sure before addressing the papilla only that the rest of the system is normal. And then you've got two options. You can either do a papillotomy where you cut open the papilla and marsupialize it onto the mucosa, or you can, what I prefer to do is just amputate it and then, marsupialize the rest of the duct into a sort of more proximal area of the buccal mucosa. Now, if you've had prolonged obstruction with a big stone, or a prolonged obstruction from a quite tight papilla, what you can get is sometimes this massive dilatation of the duct, of the Stenson's duct, so much so that it can even be visible on the external part of the face. If you open that up and you marsupialize it, it's important to stent these ducts. So even though the duct is wide open, it's massive, and you've got a nice open ostium, these ducts are often dysfunctional at the beginning, and you still can get stasis of saliva in this area. So they call this a megaduct if it's dilated by more than 10 millimeters. So they recommend still placing a stent in these cases to ensure salivary flow and that you don't get stasis in these saggy or dilated parts of the duct. These dilated ducts, they also recommend sort of pulling it from the gland, because they might have extra length, and then amputating it a little bit shorter to give a little bit more tension on the duct to prevent that sagging of the duct itself. Then if you have a distal or focal stenosis, so not at the papilla, but just in the distal part of the duct, either, like I said, you can use a guide wire or your endoscope, a beveled endoscope, or just a normal endoscope, or a bougie dilatation works quite well. For your middle segment focal stenosis, a balloon dilatation has been shown to be highly effective. Or even that Colenda introducer set from Cook Medical. Your most difficult ones is where you get these stenoses or issues at the hilum of the gland, because people have used the endoscope to dilate it with the tip of the endoscope, but the studies have showed that the long-term benefit is very poor for these kinds of issues. So you either have a few options. You can, if you have it available, you can use Botox to paralyze the gland, and that will eventually, after multiple courses, start atrophying the gland. Or you can resect the gland, or in one instance, I've actually tied off the duct completely, so that the saliva can start leaking out and cause autoatrophy of the gland itself. And the patient did very well. With combined parotid techniques, I think it's important just to divide the duct to make it easier for you for an approach. From the papilla to the anterior border of the masseter, it's amenable to a transoral approach, providing the patient doesn't have trismus or teeth that can get in your way for access. From the anterior border of the masseter to the hilum, you can use an endoscope to locate the stone and use an external approach and do a small local cut down to remove the stone and then stent that duct. But if you have very interglandular disease, I think a purely external approach would be advised, where you just remove the gland itself. So this is the flow diagram that we use at New Somerset Hospital. And you're welcome if anybody wants access to it, I can forward to them. So if a patient presents with obstructive salivary gland disease, we will do a high resolution ultrasound, and either it'll be, with a calculus or without the calculus. For parotid stones less than 3 millimeters or submandibular gland stones less than 4 millimeters, sialendoscopy works extremely well, especially again with these floating stones, and these patients do extremely well. Your intermediate stones between 3 to 6 millimeters or 4 to 6 millimeters in the submandibular gland, you might have to use a combination. Sometimes you're lucky, you can still attempt with the basket, but you have to be aware that there's a risk of breakage of the basket, which does happen on occasion. But if you have available, sometimes we get the rep in and we use a laser to fragment the stone. We don't have the microburr. After you fragment the stone, you can then proceed by removing it with your forceps or with your stone retrieval baskets. For the large calculi, you can still do sialendoscopy to see the location of the stone. And if it's intraductal, and this is very important, proceed with an open procedure, the stone, we recommend that the stone has to be palpable. If you see the stone and it's intraductal, it's quite proximal, but you can still palpate it and you can see it with an endoscope, you can then proceed with a combined sort of procedure. But if it's intraglandular and you can't really palpate the stone, I wouldn't recommend proceeding with an a combined procedure. There we would proceed with a gland removal. If we looked at the obstruction without the calculus, it can either be ductal stenosis or chronic inflammation with mucus plugs or debris that you get in the gland. And there you can either place a stent. Now again, we don't have stents available. So in the adults, we would just use a Gelco. So I think the 16 gauge Gelco, it's the gray one, has a external diameter of about 1.7 millimeters, and it's about 50 millimeters in length. So you cut it down a little bit, place it in the duct, and then suture the distal into the buccal mucosa. So we don't really buy the stents, we just sort of make an alternative. In the pediatric patients, especially those kids with recurrent juvenile parotitis, what works well is the yellow Gelco. I think it's 24 gauge. They have a diameter of about 0.7 millimeters. So you can use that to sort of flush your steroid solution into the ductal system. Now, other ways of fragmenting your stones can either be intracorporeal or extracorporeal shockwave lithotripsy. Intracorporeal is basically with a laser. We use the holmium laser, either the 200 or the 270 micron fiber laser. The setting has to be at litho or fragmentation, and we use 2.5 watts, and that delivers 550 millijoules of energy at a frequency of 5 hertz. Now, extracorporeal shockwave lithotripsy, very shortly, makes use of electromagnetic sort of sound waves or shock waves, or a piezoelectric system, and that can fracture the stone, and then they either pass spontaneously, or you can then proceed with your baskets to sort of remove those fragmented stones. But this is not available in South Africa, so I have no experience with this. Post-procedurally, you can have some tenderness over the gland and the duct with a little ductal edema. So don't delay your endoscopy. Do it early after your extracorporeal shockwave lithotripsy, because the last thing you want to do is to do stone retrieval in a duct that's quite edematous, and it can have some give some petechiae on the mucosa and on the skin itself. Post-operative care, we give simple analgesics and recommend some sialogogues. If you can, give some vitamin C for them to suck on, or just suck on some sour sweets. Warm compressors seem to still to work well, but I think probably the most important thing is good oral hydration. I tend to give 24 hours of prophylactic antibiotics, purely, especially if there's a lot of debris or cloudy saliva. With the irrigation, you'll find there is always some extravasation of that fluid around the gland. And for that reason, I give some antibiotics for 24 hours. I don't routinely give steroids, and normally the swelling, depending on the extravasation, will resolve in about 24 to 48 hours. If it's a short segment distal sort of part of the duct stenosis, a stent for about a week to 2 weeks is adequate. Very frequently, a patient finds it quite a nuisance, so then they pick on it, and then it sort of the stitches tear out, and then the stent comes out on its own. If the stent is in after the first week, you can use that stent and use a little cannula gel coat to irrigate that duct again with some saline or some ringers in the clinic or outpatient setting. But for your more sort of recurrent stenosis and strictures, I would recommend leaving or they recommend putting a stent for 2 to 4 weeks if it stays in situ. Complications can either be acute, so your ductal injury, bleeding, entrapment or breakage of the basket, lingual nerve injury. Very rarely you can get injury to the buccal branches of the facial nerve, or your delayed complications can be hematoma, abscess formation, stricture after removal of the stone. There has been a case report of the swelling of the tongue after removal of a stone from the submandibular gland duct, and then obviously a ranular or silocele from micro tears in the ductal system. Excuse me. So pearls and pitfalls, and this is I think this photo is a very good example. I don't know how many of you can see an orifice and a non-orifice here. But if you use a bit of imagination, and this is often what we are confronted with intraoperatively in theater, and that's why it's important to check in the outpatient setting. But if you use your imagination, if you see my cursor, I don't know if it's visible on your screen, but there's the orifice on the one side, and there's no orifice on the opposite side. So you can see it can be very, very tricky. So the first thing that I want to emphasize and re-emphasize is patience, patience, patience. A colleague of ours, when he first attempted sialendoscopy in private, took him about 4 hours. So you have to draw the line of how long are you going to fiddle and struggle, and when are you going to abort, and just counsel your patient, accordingly. I think for us, we averaged in the beginning about 1.5 hours, and we've brought it down to about 1 hour. So you need to go and plan appropriate amount of time when you do these cases. I'm sure in high volume centers, and especially if you start doing it an outpatient procedure, it can be done within 30 minutes. They say the average is about 39 minutes actually. The other thing about ultrasound, the ultrasound often undersizes the stone, and that is dependent on the size or the structure of the stone. If you've got a elliptoid sort of stone, just by pure physics, the apex of the stone can throw a shadow to the lateral parts of the stone that you won't visualize on the stone. So they might measure a stone of 3 millimeters in length, and intraoperatively, you will often find that it's much longer, so 4 millimeters or 3.5 millimeters in length. Please manage the mucosa actively. Everywhere that you grasp with your forceps or your pincette, that can start looking like a punctum. So especially if you grasp around the punctum, be very aware of where you grasp the mucosa, because once you lose that punctum, it becomes extremely difficult of finding it again. And then if you create a false track, that's the end of your procedure. So topical anesthesia and versus infiltration. So they recommend from the outpatient setting, you can use something like a Remicade gel, put that around the papilla to numb it. And once you're in the glandular, the ductal system, you can flush it with a lignocaine sort of combination solution, sorry, and that will give you adequate analgesia. If you do infiltrate the floor of mouth or the buccal mucosa, I would only recommend doing that if you proceed to a combined or an open procedure. And the reason for that is once you infiltrate that mucosa, it becomes boggy and it becomes friable and it tears and it starts to bleed and the whole situation becomes a mess. As I mentioned before, you should be comfortable to convert, especially if you're, even if it's a small stone, but if there's breakage of the basket and it becomes impacted or there is, you can't retrieve the residual remnants of the basket, you need to be able to convert to an open procedure. Be very gentle with your dilators and your lacrimal probes, otherwise you can cause a false tract. One of the areas that we find extremely difficult is the mesenteric bend. They recommend releasing the tension on the cheek. And very importantly, if you see this dark partial moon on your screen, stop. That is what you'll see before your scope breaks, which is not what you want because these scopes are quite expensive. The other thing, another is that after you removed your primary stone, always scope the rest of the ductal system and flush it, because there is a possibility of finding a second or even a third stone. If you use the laser, always withdraw your camera away from the laser tip, because that can damage your scope. People have damaged their scopes doing that. If you introduce your scope and you see sort of these spider web, very white spider web sort of structures around you, do not start your irrigation. You are in a false tract, and then immediately abort your procedure or convert to a cut down procedure. Then failure of the complete removal of the stone does not equate failure of the procedure. Few studies have shown often they try and fragment the stone, and then they will have part of the stone that is impacted on the wall of the duct. Don't try and forcefully remove those impacted parts, because that can lead to a tear in the ducts. By just restoring the flow, most of these patients will remain asymptomatic for long periods of time, even if you leave parts of those stones behind. And then last few tips is, if you do a partial parotidectomy for obstructive salivary gland disease, try and explore the duct and follow it more anteriorly to the anterior border of the masseter and ligate it at the anterior border of the masseter. The last thing you want to do is do a partial parotidectomy, leave some of the duct behind, and then there's some residual stones that can lead to infections and other problems. So I would recommend, if you do a partial parotidectomy, follow it all the way to the anterior border of the masseter, because if there are residual stones, you can then find it intraorally if it's anterior to the anterior border of the masseter. The same thing goes for the submandibular gland. If you, before ligating the duct, if you remove the gland, flush the proximal duct, flush it, and try and use an endoscopy to check for any residual stones. And then lastly, they described that by Lewis et al. Has shown that you need to do about 30 cases before you start becoming proficient. And after 50 cases, your complication rate starts going down. So it has a steep learning curve, but it can be quite rewarding for your patients. Now, I just want to highlight a few literature articles. I don't know, Matt, how am I doing for time?
We're all good. It's very interesting. Thanks, Vincent. Please continue.
All right, so this is a study done in South Africa in one of our private institutions up in Joburg in the Gauteng area. And this is done in private practice from 2008 to 2018. And they looked at sialendoscopy as a successful therapeutic intervention for different obstructive etiologies for obstructive salivary gland disease. And they defined the success as if after the procedure and the obstruction was treated, that number one, the patient remained asymptomatic on follow-up, and number two, if there were no complications during the procedure. So over that 10-year period, there are 39 patients treated for obstructive salivary gland disease, but 24 were excluded because they were unable to obtain consent. So in the end, they included 15 patients, of which 6 were male and 9 female, 8 were parotid duct obstructions, and 9 were submandibular gland obstructions. 10 of these patients had sialolithiasis, 1 had a stricture, and the others either had complications during the procedure or had a normal duct. There were 2 cases of bilateral sialadenitis. And the success rate was 73%. They had 4 failures. 1 where there was excessive bleeding during the procedure. The other one developed an abscess. And the last one, they had the extraction basket breakage. The second thing that they looked at is sialendoscopy as a diagnostic procedure. So 7 cases at sialogram, all of which showed obstruction. 4 cases at ultrasound, out of which 3 of the 5 glands evaluated showed obstruction. And then there also some of the cases at CT evaluation. Now, if you look at this at sialendoscopy at the bottom here, so versus sialography, the sialendoscopy was able to find pathology in all of the cases. So the 7 cases that had sialogram that showed obstruction, they found pathology with the sialendoscopy 7 out of 7 times. With the ultrasound had 1 false positive case where they found nothing on sialendoscopy. And then the CT correlated well with, the sialendoscopy correlated well with the negative CT. But there were 2 false positive glands on CT with negative sialendoscopy. Now you can say maybe the stone passed, or maybe the technique wasn't sort of adequate to find the stone, but yeah, so that was quite interesting. So radiology was accurate in making a diagnosis 73% of the times. And if you exclude the 4 failures, sialendoscopy was actually successful of making the diagnosis 100% of the times, including the failures that brought the success rate down to 86, 87%. Then another small study done at our institution by Dr. Atkins, my predecessor, and Simon Honnett, one of the registrars that I've presented on the series. They looked at sialendoscopy, which is in literature well described as a treatment option for recurrent juvenile parotitis. And they did a retrospective view of 5 kids that had sialendoscopy. You can see here, these are the 5 children aged between 5 and 11 years. 4 of them were male, 1 was female. And you can see, so most of them were symptomatic for almost for a year prior to the intervention. One patient was symptomatic for 4 years prior to his intervention. And you can see all of them have at least had 4 episodes of symptoms. One case was bilateral. So you can see at least 4 episodes of acute sialadenitis. Very interestingly, after their procedure, none of them required further treatment. So again, so this reaffirms what is found in literature is that sialendoscopy is a very useful method of treating these patients. And the duration of the follow-up was anything between 9 to 29 months in this case series. I'm running a little bit short of time. This isn't a very good study, but I'll go through it very briefly. So they said they wanted to compare sialendoscopy with conventional methods of treating sialolithiasis. And the way that they went about it is they did a case control sort of study, a group with 50 patients, and they basically had 25 patients that had sialodenectomies, they were the cases, and 25 patients were the controls that had sialendoscopies. Now the patients that had sialendoscopies were deemed the ones that had non-palpable stones of less than 6 millimeter, which is quite big. So again, there's a selection bias, and they excluded all the patients that had sialodocotomies or lithotomies, so the palpable stones that are less than 6 millimeters. So, and those are the stones that would generally be sort of more amenable to sialendoscopy. Anyway, moving on. So all the patients had preoperative ultrasound, and where the diagnosis was inconclusive on ultrasound, they had CT. So a few things I want to bring your attention to is you can see the mean size of the stones with sialendoscopy was actually quite big. So it's 5.3. So that's larger than our recommendation for pure sialendoscopic cases. So many of these cases, they use the combined procedure, and you can see the standard deviation is up to 2 millimeters above 5.3. And very interestingly, so they had 18 complete removals of the calculus with sialendoscopy and 7 partial removals. Of those 7 partial removals, 3 of them they were unable to retrieve with follow-up endoscopies. The 3 of them were unable to retrieve anything, sort of any part of the calculus at all, and those patients ended up with removal of the gland. The other 4 that had partial removals, in other words, where part of the stone was impacted and left within the ductal system, they became asymptomatic after the procedure. So even though as I mentioned with my polls, even though you are not always able to remove all of the residual parts of the stone, as long as you restore flow, patients can become asymptomatic. And I think the most important thing for me from the study is to show that out of 25 patients that had sialendoscopy, and that's excluding the patient that had sialodocotomies, you were able to spare the gland in 22 of those 25 patients. And I think that's the important role of sialendoscopy. And I think this is the last study that I want to highlight. This is the retrospective analysis in patients who were diagnosed with sialolithiasis or ductal scars between January 2011 and June 2016. And it's a retrospective analysis. They had a total of 38 patients that fulfilled the diagnostic criteria, but only 22 were included because the other 16 were lost to follow-up. 12 had sialolithiasis and 10 had ductal scars. The stone sizes range from 2 to 10 millimeters. You can see with the lithiasis group, they had a 40-month follow-up, and with the ductal scars, they had a 47-month follow-up. If you look at the first group of sialolithiasis, You can see the range of the stones. You can see the 3 cases that had multiple stones, 3 stones, 2 stones, and 3 stones. But you can see in 11 out of the 12 cases, there was complete symptom resolution. The one case where there was a partial sort of removal of the stone, they did repeat endoscopy 60 months later when the patient became symptomatic again. And then after that removal, then the patient became asymptomatic. So eventually they had a 100% success rate. And you can see for the larger stones, they did use a combination with lithotomy to remove the larger stones with sialendoscopy. But again, so in all of these cases, they were able to spare the gland. In the SCAR group, it was less successful. So 6 out of the 10 had complete symptom resolution, 4 had partial resolution, and that was a sort of successful management of ductal scars in 70% of the cases, if you look at the symptoms that they had. Yeah, so in conclusion, I think sialendoscopy is a good, reliable, minimally invasive procedure. It can be diagnostic and interventional benefits. It is gland sparing, and it can start saving sort of operative time once you start doing it in the outpatient setting. It's been shown to have long-term good outcomes, but it has a steep learning curve. Thank you very much. And these are some of my references not mentioned during the talk.
Thank you very much, Vincent, for a brilliant presentation, and thank you for sharing your experiences and some very practical aspects in terms of sialendoscopy. So thank you again very much. I'd just like to encourage anyone who's still listening to please raise your hand if you have any questions, or post them on the chat function. Just one practical question from my side. I know you guys regularly use the dexamethasone steroid rinses for whether it's Sjogren's or juvenile recurrent parotitis. How do you mix that rinse, Vincent?
So there's different concentrations that you can use and different sort of products that you can use. In the literature, they use triamcinolone or Kenalog, which is 5 milligrams per ml. So that's what they use in the reference textbook that I use. In our institution, we use hydrocortisone, and I think it's 125 milligrams in an ampule. We would then mix that in a 50 ml normal saline or Ringer's bag, or 60 mls, diluted to 60 mls, and then use 20 ml syringes to irrigate the gland. The other sort of little tip that I just want to mention, and Dr. Meyer is welcome to also add if she's on the chat to give her opinion as well. She's a lot more experienced than I am. If in the beginning I used to give very high pressure ductal irrigation, but I found there's a lot more extravasation and the patient has a lot more postoperative pain. So more recently I've been doing sort of a gentle irrigation. You just want to stent the duct to be able to visualize what you need to see.
Thank you very much, Dr. Pretorius. I'd just like to invite Dr. Meyer, also a very experienced sialendoscopist, to comment if she's on the chat.
Hi, Matt. Vincent, great talk. So the post-op, there's 2 things that you said. They need steroids. So the one thing that helps with the pain is to actually give them oral steroids, because they are so swollen that for the pain, a short dose of like 5 days of steroids is life-saving for them. The other thing you said, give them sour things? Please not, because now you've already stressed this gland and now you kind of want them to produce more saliva. So they must actually be on a bland diet. So they must stay away from fruit. They must be like pastas, bland diet. It just helps them, because post-operatively, they are swollen. It's not an easy operation. We tell them, they're going to be slightly swollen, but they often end up like chipmunks, and it's very sore. So things like hot compresses can help, but it's not an easy post-op period that they've got to go through. So just for the beginners, stay away from the stenosis. Vincent has told you very nicely to do. If you're a beginner, avoid them. I still take 2 hours, and I'm more experienced than probably the rest, just to get into the duct. So in the beginning, that's all you need to practice to get in there. Go for the small stones, because I've got a laser, and you think you're going to be a cowboy, you're going to break down the big stones. But go for the small stones. So if you start starting sialendoscopy, go for the ones that you're going to examine. to see like the parotitis, the chronic sialoarenitis, go for the small stones, and in the beginning, stay away from the stenosis. Thanks, Matt.
Thank you very much, Dr. Meyer. I see Dr. Kafui Seryo is here on our chat from Ghana. I'm not sure if, Kafui, if you had much experience in sialendoscopy in your centers in Ghana?
No, currently we don't have the Sialendoscopy set available yet. So the only experience I have is what I learned in Israel, but that's about 3 to 4 years now, and I've not been able to put that to use yet. So we are in the process of trying to acquire the equipment, but for now, I don't. Down here, we don't have any experience now.
Okay, thank you very much, Kafui. I don't see any further questions. I don't know, Dr. Pretorius, any closing comments you'd like to make? Any final statements?
No, that's it for me. Thanks for the opportunity once again. I hope it was, yeah, insightful.
Okay, thank you again for a brilliant talk, and we'll see everyone again on Friday at 8:30 for our case presentations. Thank you.